With this week's Cardiology Countdown, we have two looks at heart failure management and also on the big issue of ETT screening. So beginning at the number 3 spot is a report from the AHA's Get With the Guidelines heart failure program that looked at the correlation of following the guidelines and meeting the core measures for the heart failure in addition to the acute MI measures. At about 280 hospitals, they found that the hospitals that were highly adherent, that is greater than 95% on the scores, to both the heart failure and acute MI scores had an associated lower hospital mortality, whereas hospitals that had just good performance in one but not the other area seem to have a similar mortality to hospitals that did just average adherence to guidelines in both of those. So this suggests that the quality improvement has to be a broad one across a hospital, but if so, that's associated with excellent outcomes. So encouragement for us to improve our systems of care. At the number 2 spot is an analysis from the placebo arm of the Everest trial, looking at the very vexing problem of worsening renal function in patients admitted with heart failure. Not surprisingly, it was seen that poor renal dysfunction was very prevalent. About 50% of patients had an eGFR of less than, or creatinine clearance less than 60. But worsening renal function was seen in about 15% of patients in hospital and an additional 11% of patients post-discharge when looking at a 4-week creatinine level. And so this is at first an eye-opener that one has to build a system to monitor the post-discharge creatinine, and each of those is associated with worse long-term outcomes. And so building the bridge beyond hospital discharge, certainly for these high-risk heart failure patients. And at the number 1 spot is an interesting analysis from the Johns Hopkins family study of atherosclerosis that looked at whether ETT screening would be helpful. And so they did an analysis where they got a cohort of about 1,280 patients with an acute coronary syndrome and went to their siblings and did Framingham risk scoring and stress testing to see whether that would be useful. Interestingly, a positive stress test was seen in about a quarter of men and a smaller percentage of women, I think about 10%. If it were positive, that was correlated with a high risk of events over the next 8 to 10 years. But most of that risk seemed to be predicted more by the risk factors than the Framingham risk score, so that in terms of determining therapies for that 8 to 10 year period before a recurrent or a new event, using the ETT didn't seem to add much overall. And so it gets us back to more basic risk factor management screening and therapeutic lifestyle intervention and guiding statin and aspirin therapy based on lipid levels and overall Framingham risk score. So with this week's Cardiology Countdown, I'm Chris Cammett.